Good morning. This is the Committee on Health and Homelessness. Today is Monday, November 20th, 2023, 9 o'clock a.m. We are in conference room 329 at the State Capitol and also on live video conference, our House YouTube channel, I believe. Members, this is an informational briefing of the Committee on Health and Homelessness. Today we're going to be having a briefing from the City and County of Honolulu, an update on the Act 208 Transition and Community Paramedic Medicine program that was implemented and started in 2021 as we were in the depths of the pandemic. So even while we were in the pandemic, our first responders were doing an excellent job taking care of our community and also reforming the system of emergency services county-wide, providing in many ways a model for what will be, I think, and I hope, community paramedicine across the state. We will also be getting an update on the core services program, the City and County of Honolulu's community paramedicine program that I just briefly touched upon. We have with us today Dr. James Ireland, Director of Honolulu Emergency Services Department, and his Deputy Director, Ian Santee. So without further ado, and thank you to the members of the public who were patient. We had a little bit of a technical difficulty, as we always seem to do. We're better since coming out of the pandemic with all things remote, but of course there's always some challenges. So I will turn it over to Dr. Ireland and Mr. Santee.
Good morning, Chair. Good morning, members. It's a pleasure to be here today. We have, I think, some exciting things to tell you that what we've accomplished and learned as a team, the City and County of Honolulu, both with EMS and with our new CORE program. CORE is Crisis Outreach Response and Engagement. It models, but we think is better than, some of similar programs on the mainland, such as Cahoots, and there's some others in cities like Portland and Denver. Minnesota has a very progressive community paramedic program. But some of the, let me back up. Traditional emergency medical services. The City and County of Honolulu has been providing ambulance service since about 1920. We had our 50-year anniversary in 1970, and that was commemorated with ashtrays, if you can imagine that, how far we've come. Since the 70s, though, we've had the birth of the paramedics nationwide, where we went from ambulance attendants with minimal first aid skills to now full-blown procedures, drugs, protocols that are in many ways similar to nurses and physicians in the emergency room. With that came more equipment, larger vehicles, and different names, because in the city we had what was called the health department up until about 25 years ago, and it was an ambulance division. And now we have the Department of Emergency Services with the EMS division. So as EMS has evolved, this is another evolution of EMS, community paramedics. And traditional EMS is what we call now 911 service. Someone needs help, they call 911, we respond, and we do treatment, sometimes advanced life support, and then we take them usually to the hospital, emergency room. Occasionally now we have alternate destinations where we might take them to an urgent care for a more minor emergency. But it's not without its issues. And one of the issues is people who what we call frequent callers or hyper users. There are people in our system who call 911 every day. And it's not necessarily for emergencies, what we would consider emergency. It's for things like I'm hungry, or my acrylic nail came off. And these are true calls. I'm not making any of this up. I have gout in my toe. I'm constipated. I can't sleep. So these frequent calls now are clogging up the EMS system, where and it's very frustrating for our paramedics, because if they go on a call for someone who wants a sandwich and they're tied up with that, if someone has a heart attack 2 blocks away, then that person may have to wait for a further away ambulance. So it's an inefficient way to run the system, and it's a frustrating way, and community paramedic is one avenue to address that. Now, some of the earlier paramedic programs in the mainland dealt with geographic issues. So for instance, in rural Minnesota, there was maybe no hospital, so they relied on the EMS providers to do primary care type care or urgent care type care because of the just huge distances between healthcare. On the island of Oahu, you're pretty close to healthcare no matter where you are. I mean, it's a 15-minute Uber ride probably anywhere on the island to get you to some kind of healthcare. However, we have more socioeconomic, I think, issues with healthcare challenges. And what I mean by that is people who, I'll give you an example. We went to public housing, one of our ambulances, and I ride along from time to time or go to calls so I can see what our team is seeing. And the lady says, the patient's mother said, why'd you call? And she said, my daughter has a fever, 2-year-old daughter. Very common for anybody who's a parent to know that children get fevers. Okay, and why did you call us? What did you need help with? Well, I need to go to the hospital. And did you call your pediatrician? And she said yes, and he's the one who said I need to go to the hospital. And they asked, did you want to go in your own car, or did you want to get a ride? Because it wasn't an emergency, but we still were offering care and transportation. And she said, well, I don't have a car and I don't have any money. And so what she was left with was 911, and our team was more than happy to take her, and we took her to Kapilani ER, the baby, and so, it's an $1,800 ambulance ride, and she was probably on Medicaid, so government paid. It was an ER visit, when really what was needed is a primary care visit, which is probably 10 times less expensive. And that's just one example, but we're seeing that over and over again, especially with the hyper users calling for this. It's very expensive healthcare. And it's not that we don't want to help people. We do want to help everybody. We respond to everybody who calls for us. But what I would say is what we want to do is give appropriate health care. And if it means a community paramedic visiting with somebody once a week or even once a day to prevent a 911 call and an ER visit, that's saving the system lots and lots of money. The other thing is if I go to the ERs probably a couple times a week, most of them on Oahu, to visit, see how things are going, see how our crews are going. They're all extremely busy. And if you look back 10 or 15 years, hospital capacity is actually shrinking on Oahu. We lost St. Francis Laliha. St. Francis West closed and now is reopened as Queens West. Wahiawa General Hospital is a shell of what it used to be 10 years ago as far as services. The ER is still there. It's a very nice ER, but the actual capacity is very small. We've lost nursing homes. The WNRC, which is on Wahiawa General's property, is now closed. That had over 100 patients. And so if you go to any ER on Oahu today, it's going to be very, very crowded. And that means people wait 3, 4, 5, 6 hours. Even the ambulances sometimes are waiting up to an hour to offload their patients. That's how busy it is. So anything we can do to appropriately redirect healthcare to at the appropriate level will help the system, not only financially, but we want our ERs to be available for emergencies. We want Queens to be able to take an emergency trauma. We want Straub to be able to accept the burn patients, because these are specialty services that Polymomi for a heart emergency, or Castle for a cardiac emergency. Queens West, because it's the only hospital on the west side. Wahiawa General, so important to Central Oahu. So we want to keep there's plenty of business, and so if we can redirect some of these calls to other facilities, and that would really help. So this act that allowed for community paramedicine was huge for us. It allows us to now branch out into just what it says, community paramedicine, where we are doing more preventative care, redirection, primary care, and one thing we say is we like to keep small problems small. So if someone has a foot wound and a community paramedic can give antibiotics and some basic wound care, and we prevent a rip-roaring septic shock infection that needs to be in the ICU for 2 weeks, amputation, that's a win for the patient and the system, and not just a financial win. So I think with very little investment, we can actually do a huge difference for our community. I can't really speak for the neighbor islands because I don't work there, but at least on Oahu, where we do have a very wide range of patients from different socioeconomic backgrounds, some cultures that are a little different, and clearly access to healthcare is not equal. And so if we can help in those areas, that's just a win for everybody. And at the same time, alleviating ER overcrowding, alleviating EMS excessive 911 calls. And when a 911 call comes in, it's not always just EMS that goes. It involves sometimes the police department, the fire department, the sheriffs, other agencies, Ocean Safety, and we want them to be able to do their regular work too, that they're called to do. So that's kind of it for a big, long opening statement, but I hope that paints a picture. But again, we're excited to be here, and I don't know if you have any questions or you want us to go a little more into our detail into our programs. I'll leave that to you.
I think you have a presentation if you want to take us through that.
We do.
And then we have questions as we go along.
Sure.
Yeah.
Okay, again, good morning, Chair and members of the committee. Ian Santee, Deputy Director, Honolulu Emergency Services Department. So today we're going to talk about updating you on Act 208 and our transition and how our Community Paramedic Program, or CORE, has evolved. Act 208 was back in session of 21, and it was a law that was passed by the legislature that allowed the city and county of Honolulu, or actually any entity with a greater than 500,000 people on the island, to be able to be, they would be running their own EMS services and also committing $3.5 million every year out of the fund to the county, other the EMS special fund, which is paid through vehicle registration tax. So emergency medical services fees, this allows us to collect a new section in the law allows us to collect the fees and be expended through the city and county of Honolulu. Prior to the passing of this bill, all money collected for ambulance service fees was deposited into the state's general fund. This is the current rate of what an ambulance is as of today. It is currently $2,240 for an advanced life support case, which means that somebody that gets an IV started or given medication, or $19.95 if it's basic life support if we are transporting you to the hospital. This is controlled annually by the Director of Health. It's in the law already that allows the Director of Health to automatically sign a notification to the providers that says the insurance, the rate will go up by 10% automatically every year as long as the Director of Health agrees to it.
I think it's fair to note on this slide is, even though these are the charges statewide, and the city and county of Honolulu, even though we can set our own billing rates, we have chosen to follow the state's rate. This isn't necessarily what we collect. We collect basically what insurance pays us. And so if Medicare has a rate for ambulance, which it does, and per mileage and any things we use, that's what they pay, that's all we get. Medicaid has a rate, that's all we get. Commercial insurances, each entity has a right to negotiate a contracted rate with those insurances. And I know at the city and county we've looked into that and we're willing to do that. I don't know the status of that today, but what we receive is actually far less than what's actually billed.
Okay, thank you, Dr. Arlen. So part of the transition, it began in the fiscal year 2022. The reimbursement rate with the county was up to $46 million, and $3.5 million of that was deposited from the special fund for fiscal year 22. In fiscal year 23, which just ended this past June, we received $8.9 million from the Department of Health, plus an additional $3.5 from the general fund. We've already taken the responsibility to start over the billing process. Our billing process was a little behind. We didn't receive Medicare approval till earlier this past January. So, I mean, we received the approval about maybe in September, October, and it was only allowing us to bill back to January. We're in the process of getting an appeal with the Medicare to bill back further back to the July 1st date. There were some challenges with it because of the transitioning from the state to the city. A new Medicare number had to be gotten, as well as some other procedural stuff. Administrativity was taken care of. Currently in FY24, which is currently today, $4.4 million is going to be received by the city, plus the additional 3.5 that I've mentioned earlier. And all the billing comes directly to the city. And next fiscal year 25 and forward, we will just be receiving the $3.5 million from the Department of Health. So a billable trip, this is from our billing company, is any trip that pretty much we transport and provide care to the individual. So as of last month, 80% of our calls are advanced life support, 18% of them are basic life support. Average loaded miles is about 5, and what that means is that's how many miles on average of all the cases we transport throughout the island of Oahu, we transport about, they average about to 5 miles. And then the payer mix, it shows that 50% of the people that are paying is self-pay or patient, 11% is coming from insurance, generalized insurance, 11% is coming from Medicaid, and then a 28% is coming from Medicare. The reason why the numbers are a little skewed, again, we sent out all our bills for the first time back from retro to July 1st of last year, back in August of this year. So a lot of individuals did not have insurance information on their, when they collected by the EMS transport, so they were sent out as a self-pay. And now they're working through trying to put their insurance into the system, which is online, so that way they can be billed through their insurance. As Dr. Ireland pointed out earlier too, that we are in discussions with the providers to come up to a participating rate, participating provider rate that we are able to work with the insurance companies. On average, again, as you notice, the bill is $2,200. We regularly receive about half of that is what the insurance company pays. Net collections is how much we collected up to year to date. So on this slide, it says back in October, this is printed October 10th, is $5 million, and we had 34,000 transactions. I can tell you to date, as of this morning, I looked at the income, the money that's been in, we got 11.9 million we've collected, and we billed out $178 million. So $178 million is billed out. That's based on our roughly of 60,000 transports back to July of last year. So as noted, it's a fraction of the entire amount, and we're still working through collection. Again, everything was billed out, and we're working in the money to come back in through the different resources of if it's a workers' comp insurance or a commercial insurance, or if it's a private pay or Medicare or other. I'll take a pause there if there's a question, Chair.
Questions?
No?
I actually do have a question.
Yeah.
So it would seem to be a stunning number, but understanding that this is a new system for you folks, understanding that the difference between what's billed and what can be collected.
Yeah.
Do you see it improving? And then in comparison, because prior to this, it would have been the state
Yep.
that was making the collections. Is there a trend towards seeing the Honolulu, City and County of Honolulu being able to collect more?
So to answer your last question first, yes, and then working the way backwards. Prior to the city taking it over, this is a normal collection amount on average, meaning if we bill out $100 million, it's already taught that only 2/3 of those people can actually pay. And those 2/3 of people that pay, we're only going to collect 2/3 of that payment, because again, as we get to a couple more slides, Medicare only pays a $500 base pay, and Medicaid pays down in the $200 range, which the state has control of. So the recouping of the costs for the entities that involve Medicare and Medicaid insurance is on the lower end. The private pay insurances like workers' comp and other no fault, those type of insurance, they pay the full amount. And then when you deal with people like the generalized insurance, like the HMSA, UHA, Kaiser, and I can't name them all, there's thousands of them, but those general ones, they have a negotiated rate just like all of us do for our regular physician that we see out there. There are some things that we are doing differently that are streamlining internally our processes and our ability to collect at a more efficient rate. And it just has to deal with the follow-up and the changes that we made internally for that. I can't speak to what the state did or didn't do, but for us, we feel that we've improved our processes internally to address the issues to get a better efficiency. We anticipate on average probably collecting about $40 million to $50 million.
When you're fully up and running?
When we're fully up and running.
A year.
A year, yeah. When we're fully up and running. And that also is things, as Dr. Ireland pointed out, about we do have some control at the city to initiate certain billing fees. Right now, the law does allow for to bill for treat not transport, which you folks did pass in the previous session, but the administrative rules were not created for that at the state level completely. So for us at the city, we would enact it as part of an ordinance. We anticipate something. If we did, and something like that. And what that is an individual, we go to your house, you're found unconscious, you're a diabetic, we start an IV, we give you some sugar to wake you up, and you're like, this is routine for me, I don't need to be transported. So right now, that type of medical condition is a free charge.
Okay, can you pause right there? So you said the rules have not been completed at the state level. Is that still the case, and is that something that we should follow up on?
I think you would need to follow up better with the State Department of Health EMS Injury Prevention branch, but it's the understanding that as the rules were up, they were an emergency rule It sunsetted this past June, is my understanding. It wasn't a permanent rule. It didn't go through the whole process. So that rule for that would be something to follow up upon.
So prior to the sunset, we did consider initiating that fee schedule. But it's an internal debate at the city. His example was, if we come to your house, we start an IV, we give you drugs. Currently, there's no charge for that. We leave. We did spend some of our time. We spent some of our drugs or sugar to wake you up. But currently we don't treat for that. Now, I think if we did in the future decide, whether it's through these administrative rules or our own city ordinance, that we did want to do that, I think people would see that charge as fair, and we bill their insurance and that sort of thing. But in treat no transport, if we went to a, let's say, motor vehicle accident, and we go and maybe they're banged up, but they don't need to go with us to the hospital, and we gave them a charge for that, that might elicit a different response from the patient, especially if they didn't even call. We didn't call. We just a little fender bender. So we want to be very careful in how we define a no transport charge, if we're even going to do it, because we're public servants, and there's some things that we should do without charge, I think, just like the police and the fire department, ocean safety. So there's that fine line on what we would bill for and what we wouldn't. I think we'd have to have a very robust discussion at the city, including the mayor, to decide if and when we implemented that, how we would implement it. And certainly I can't see charging somebody who didn't even call for the ambulance. But if we did do a head-to-toe assessment, we did a report, we did a full examination, does that warrant a charge or not? And then another level is actually if we do a treatment. If we put you in a sling or put a dressing on or give you drugs, does that warrant a treatment? So all that is kind of bundled into treat no transport. And so I think it just needs at our level further discussion.
Is that a discussion that happens just within the county, or should that be a discussion also with the state?
Both.
Okay.
And the reason why is, so let me put it in a better perspective. And we're only speaking on behalf of the city. And I don't have a slide, but we'll get you guys the information in writing. So City and County of Honolulu responds to 100,000 911 calls on this island. Of the 100,000 calls that we respond, we transport 50,000 people. So you're like, wow, that's 50%. What's happened to the other 50% of the people? Of the 50,000 that we transport, those are the actual bills that we are sending out today. And again, these are the average numbers, just giving you guys averages, so we'll get you more specific slides. Of that, about 25,000 calls are canceled. So that's the call that our EMS providers are responding on scene, and they get canceled because the caller called back, or they get on scene and they can't find a patient. Those right there. The other 15,000 is now, that makes 90,000. Those 15,000 are refusals. Those are people that we come up, we see, we have a documented refusal because, as Dr. Island pointed out, we have you on a traffic accident, you sign a refusal for a treat and release, or we go to your house. And then the other 10,000 is a mix of people that we pronounced at scene and other standbys and so forth that we've done. So those are pretty much non-billable. It's just, those are right there.
So I think this is a really great discussion, and it highlights the complexity of it all.
Yes.
So can I ask, because this kind of goes into the arena of, where you might be called in for like a hiking accident or involving tourists.
We do it all the time.
And then how are you able to collect on those kinds of fees, especially if it uses an incredible amount of city and county resources?
So I think the fire department is the primary search and rescue agency for the city and county of Honolulu, and we don't really want to speak for them today. I mean, I think that's up to them to I think explain what goes into the rescue and their thinking on that. From our standpoint, the medical standpoint, EMS will go if there's a injury or suspected injury. So if the person has heat stroke or cramps or dehydration, or they've fallen and injured themselves. And we do go for those once the patient is extracted from the rescue scene. And if they go to the hospital, we capture the charge like we normally would on a transport. If they say, I'm good, I just needed a ride out, helicopter ride out, whatever, sign a refusal, right now we do not charge for that. So that again goes into that bucket of the 15,000 people every year we see that we don't charge for. And if you multiply that number, 15,000 by $500 or $1,000, whatever the fee would be for treat no transport, it is a sizable amount of money. It's in the millions. But if we were ever to do a treat no transport fee, I think we would want to tease out those who've been in a traffic accident and didn't even want the ambulance would get no charge versus person you're actually giving drugs to that later declines, they get a charge, but it's everybody in the middle. And I mean, there's no reason why if we went up and assessed a hiker medically, that we couldn't do a charge if they weren't transported, but it would just have to be discussed and put into the whole spectrum of charges for treat no transport.
So I would urge, because and I know your impulse is to just treat and focus on that, and all of this administrative burden is exactly administrative burden. But as we know, people get insurance for travel. People take out insurance policies for these kinds of things. So I think we need to hold our insurance companies accountable too, if they can help pay for the services, the life-saving services that you give. I think there needs to be a conversation, and certainly at the state level, we can help pursue that. Again, it's about how you're getting appropriate treatment. You also want to get appropriate payment, and I appreciate that you guys are taking a slower approach to this. But this might be the avenue when we have our constituents ask us, well, how is this getting paid for? And it's not about just cost shifting or moving the burden. It's holding folks accountable. So I appreciate that you guys are having this you're thinking through these things.
I also see in the discussion that if people are on prohibited trails or closed trails, if that should get some extra financial penalty. And I don't have an answer for that, but if we got paid extra for every time we responded to something when somebody did something dumb, we'd have a lot more money.
Thank you. Oh, go ahead, Representative.
This slide shows net collections, payment, insurance, by far the largest amount,
Yes.
2/3. And so you were saying that for your insurance payments from these insurance companies, that's a negotiated rate?
Yeah, just like anybody else, I think as a private physician, right, when all of us see our regular doctors, you
Right.
see what the participating provider rate is.
Right.
Yeah.
But in this case, don't you have a large advantage in the negotiation?
We do, in the sense that if you're right, the state historically, at least the last 10 years that I know of, has been non-participating
Right.
with any private insurance company. So the bill is the bill. The downside to that is, my understanding is the insurance company, if you're the transported patient, we send you the bill, your insurance company sends you the payment, and then it's up to you to pay the bill, which you would pay, but other people may or may not pay. When we negotiate a rate and become participating, what's negative for us is we're accepting a lower rate than the published rate, but at the same time, then the insurance company pays us electronically directly into the city account, and the only thing maybe we have to collect from the patient is a copay.
But you're essentially the only provider, so doesn't that give you an advantage in the negotiations?
Good question. The part of it is you're never going to negotiate to the maximum amount because Medicare sets the bar. Medicare is the limit on the base end, and I don't have the exact numbers on how that works out in there, but if Medicare is $500 is what they're going to pay, the amount that you can pay has to involves in that some aspect of it.
Who set Medicare as the,
Medicare is the insurance, the CMS, the federal government.
but who set them up as the bar?
Well, I mean, the federal government tells them what they're going to pay, but we do have a lot more control at the Medicaid, at the state.
In the hospitals, Medicare is not the bar. Medicare is the lower.
Oh, I'm sorry. No, and my word is incorrect. It's the lower end of the minimum. So Medicare is the minimum, and it's used as a standard. Maybe that was the incorrect word, sir.
I see.
Yeah, not the bar, but
But you could negotiate a rate higher.
oh yeah, we are working on that.
Oh, absolutely.
Absolutely.
Oh.
And our rates are higher. The collection rate is higher, but it's not to the maximum or the $2,200 that we're currently charging.
Why not?
Because of I believe the negotiated factors with Medicare and the rules of Medicare and Medicaid and so forth. Again, as Dr. Island pointed out, the Medicaid, we only able to collect about $200 from the state for people that have Medicaid.
So,
Yeah.
we have, at the city, we've procured a billing company that does, I think, 50 or 60 other EMS or ambulance services nationwide. And they're helping us with those negotiations as far as what rate to expect and what is, I guess, the word fair.
Yeah, we believe that we are getting the best opportunity for our collections. Is we just are not the experts in that area at this point. But yeah, just to point out, Medicaid, which you guys do have some say in, pays less than Medicare. So we even
Do
get.
you know why it's that low?
I honestly do not have an answer for you, and I think that would be something that you guys could look into. Because
I mean, I think there's other jurisdictions nationally that have compelled Medicaid through legislation to pay ambulances more, and
Yes.
physicians for that matter.
Yes, they are.
We can put that
Thank
on our
you.
potential to-do list.
Yes.
So, I think nobody, at least from my standpoint, nobody, I think, is expecting us to be a profitable company like a private business. We're a government service. But at the same time, we want to recoup as much funds as we can through like the car registration tax that's already in place, our billing, to minimize the impact for the service on the taxpayers. And for us, because we're a busy service, it's easier as you get to places around the state that are more rural. For instance, Lanai, it would be impossible because they just don't run enough calls to generate the revenue without some form of a stipend. I just use that as the other extreme.
Okay. The next slide, it talks about American Medical Response. They are also the sole provider for our backup on the island of Oahu. Again, prior to 2022, we've had an in-place contract where we paid AMR X amount of dollars for them to provide the backup service to us. And it shows you the call volume. Without them, on average, about 4,000 calls a year they're taking from 2018 to 2022. They're taking about 4,000 calls. I don't think you guys have that slide because that was the, yeah. Oh, you do? Okay. That's my guess. That's good that you have it. Okay. So the average again is about 4,000 calls that we're taking. And what that is that's money that we were paying them to do that backup. And it tells you the difference right here in the bottom part of that slide where the amount of advanced life support calls versus the amount of transports versus the amount of basic life support transports or Delta DOAs, cancellations, and refusals. So it just puts you in perspective. That's if the state or the city at the time had the funding to expand the services, then we could add 2 to 3 more ambulances for that. And it's also staffing issues at the same point. Today, City and County of Honolulu has 21 active ambulances 24/7 a day. We anticipate by the end of next calendar year, we should be up to somewhere between 23 to 24 ambulances. We have currently a recruit class of about 28 people in session training that will graduate in December. And we just hired a group of 13 people. So our staffing personnel is growing. And with the growth of our staffing, we are able to more and expand services. But we still need this private provider as a backup contract to additionally provide the services because, again, the population growth and the calls that happen throughout post-COVID have increased.
Can I ask a question on this? So, routinely, we would get requests from counties to add ambulance services. Because of this kind of reform, is this now something that you guys can take on wholly on yourself, or do you foresee coming to us for those kinds of
I
proposals?
think, well, as I said earlier, that we anticipate opening 2 more ambulances. Because of the transition, we put that into our county budget.
Okay.
So the county is now taking ownership as allowed by the state. Any kind of additional resources for the City and County of Honolulu is we're requesting through our county operation budget to run and to add additional services.
And that has to be probably a more efficient way of doing
It's
things.
definitely a more efficient way.
Okay.
So just for an example on our island, when we were still within this, under the state, and by the way, the state funding EMS for the whole state is a unique mechanism for just the state of Hawaii. No other state does that. But when we were under the state and we needed to contract with AMR, we actually had to pay them because the those bills that AMR generated just went into the state coffers. Now that we're separate, what we do is we still contract with AMR, but we don't pay them anything, and they're allowed to bill the patient as long as they follow the state fee schedule that we follow. So it's allowed us to expand our use of AMR, where we now have 3 of their units assisting us daily, up to 3 units with calls that are dedicated to the city. And if they have calls that they traditionally do, like interfacility transfers or things that they need help with, then we help them. It's more of a reciprocal. But there's no financial exchange between the two entities. And then AMR does the primary 911, as you probably know, on Maui and Kauai. Mm-hmm. And then they also serve, I think, as a backup service on the Big Island of Hawaii for the county fire department there. So this state is also interesting in that we have 3 models of EMS delivery within our state. We have a fire-based model on the Big Island. We have what's called third service or third government service on Oahu, and then the private model on Maui and Kauai. And each, I think, has its unique strengths, but the system works.
Question?
And there's been discussion over the years as to which is better, which of the 3 models.
I'm very comfortable speaking about the city and county of Honolulu. I started as an EMT here in '94. It hasn't been it hasn't been 30 straight years, but we have a great team. I think we have a good model, but it's not to take away from the other counties as well, the way they run things. And I think what I've seen across the nation is that when EMS was essentially born in the 70s, whatever model you were using works for your community, and if it continues to work, they should stay with that. So Big Island Fire has done it since at least the 70s, if not before, and that works for them. Whereas on Oahu, city and county, I have pictures of ambulances from the 1940s. In the 1920s, actually, the Honolulu Police Department had the ambulance. And our system works really well for us. So I've never worked on Maui and Kauai, but the paramedics there are very happy. The community seem to be happy with the service, and that works for them. So to answer your question, I think they all have their unique strengths.
I'll comment on this.
Yeah.
I think given the nature of our state,
That's the
each model is probably well fitted for the islands it serves. It doesn't mean that we cannot look with a critical eye with how to improve on each island that fits for each island and each county. So I appreciate that in 2021, City and County of Honolulu, I'm going to give a shout out to my former colleague, then Representative Ryan Yamane, on working on this issue, because this was a tough issue that we struggled with for many years. And I hope that we're going to see some benefit coming from the implementation of this. And it's going to improve the system statewide.
yes.
So I know that this is kind of, we're at the halfway point of the presentation. Any other questions on Act 208 from my colleagues? Or any closing thoughts on this part? And then we can move over to the core services portion.
No.
Okay, if we want to continue?
Okay, so part of the
I will say one more thing.
Okay, good, Dr. Arlands.
Everybody in EMS, the first responders, and to our colleagues too in the Ocean Safety Fire Department and the police, did just such an amazing job during COVID. Yes. With the uncertainty before there was a vaccine, whether or not you were going to get it, whether or not you were going to die, heroically, really. We still have COVID. They're still going on those calls. But we also have a rebound in tourism, which is a good thing. Those calls are all back. People are enjoying themselves out and about, hiking, swimming, doing fun things. People get hurt doing that. Those calls are here. Now we have the fentanyl crisis. We're going on fentanyl calls pretty much every day, overdoses. So in the setting of when we're looking at EMS as a system, I think it's also important to look at the call volume. And just this month, we had 500 more calls than last month. 500 calls in 1 month. So we do have to keep up with service. And if a community's call volume is up, they probably may need more resources. And that means investing in KCC, who trains probably 95% of our EMS providers in this state or more. It means career pathways, no matter what county you're in, and making sure that the counties, and for us, it's City and County of Honolulu, have the staffing and resources, and to recognize things like burnout. And so when we're going to talk about the CORE program, alleviating a chunk of calls that our people are going on helps to alleviate things like burnout. When I started at EMS, I started in the 80s, so I'm dating myself a little bit, but people only called for emergencies. Like it was bad if we would go on a call, and that's just not true today. We go on all kinds of stuff. And it would be shocking to some of you, I think, to see how minor some of these things are. But we still go. We still take good care of people. We do it with a smile. And I mean our whole team. They make me look good because they're so professional. I get letters every week of just what they've done for people in their lives, even if it's just comforting. But the call volume's there. The other thing that's changed EMS radically is the invention of the cell phone. When I was first in EMS, there was no such thing. So there was an accident on the road. People would all pull over, and somebody would have to be the designated 911 caller. So they'd drive off the freeway and go find a phone somewhere at a gas station and have to call 911. So my point is there was an effort in that. And there was an effort to try to help somebody. But now we have people driving down the street and see someone on the side of the road, often a homeless person. They think they're in distress, but they're often not, and they call 911. So EMS goes, the fire department goes. And that has generated thousands and thousands of calls of unnecessary response for fire, police, EMS. And that goes into that pot of 25,000 calls we get every year that nobody's there, they don't need us. And so I think that's a good segue into CORE, that because EMS and ambulance service has changed so much over my career, that we need things like CORE to divert some of those calls. And for the people we help in CORE, if we can save 300 911 calls in the following calendar year, that's huge. And not to mention just the human factor of getting people off the street. So call volume, CORE.
So CORE, crisis outreach, yes, sir.
One more. You said that $3.5 million would be paid ongoing.
Yes.
Would that need to be changed in the future?
That's a very big question or challenge, because again, that comes out of the EMS special fund. I think the 3.5 million was based upon, the way I understood it, when this session law passed, was based on the county getting majority of their share of the registration of the vehicle tax. So, and there is also a cap on that account, that fund. So we definitely welcome the opportunity for more money and funding, of course.
I mean, we have a lot of fees that are stuck in law, and sometimes they don't get upgraded for a decade,
Yes.
and it's sort of unconscionable. I'm wondering if that fits.
So I would never say never. And so we would love to revisit that because, again, call volume's going up, the types of calls are changing. We want to be there for everybody, And I'm just going to brag again about our team. Despite this increase in call volume, we have still maintained our state set response time guidelines. And even though some of our units are running 18 calls in 12 hours. So as it gets busier, as we need to hire more people and staff more ambulances, that may need to change. And we would appreciate the opportunity to discuss that in the future for sure.
Well, I think you have to make the initial proposal.
Okay.
Sure.
What I would urge, I think it's there's always opportunity for conversations, but I also think that part of the piloting of this program is to really see, because of what we were concerned about on our end was that the state was not collecting as much as they could. So if we can see the collection response on your end higher, we want to make sure that we, again, are really charging the people who are responsible for this. And insurance plays a big role in this. Insurance companies, this is part of their budgets. This is why we pay health insurance, is to make sure that we get payments for health services, which you folks clearly are. Now, health insurance is complicated, so
Yes.
that's why, you know, there needs to be this kind of ongoing subsidy at the end of the day, because the $3.5 million is in fact an ongoing subsidy at some point, and we subsidize the rural communities for some of the reasons that we've already kind of discussed. But I think it's something that definitely we need to have a conversation about.
I think if we revisit the billing in 6 months as this bolus kind of rolls in from the late charges we sent out, we'll have a much better idea of where we are.
Yep. Okay. Okay, CORE, Crisis Outreach Response and Engagement, is our segue into, again, another previous law that was passed a few years ago, community paramedicine. And the title community paramedicine doesn't mean you have to be a paramedic. It's about providing the pre-hospital care in, born in the mainland, more so in rural communities where they didn't have access to health care. It's addressing frequent callers. It's addressing those that have limited resources and services. So our mission of CORE is through the collaboration with the array of city programs and street outreach, our efforts are to provide resources and comprehensive coverages to all people experiencing unsheltered homelessness. We respond and follow up with community crisis calls that are nonviolent and do not require emergent medical assistance. So, and that's one key thing to point out. Everybody that works in CORE, it's not a 911 call. It's not an immediate response. We may take up to 24 to 48 hours to get out to the person. If it's something that needs immediately, we direct everybody to call 911. Our main values, again, engaging and improving the quality of life for all people through compassion, empathy, and professionalism. Effectively and respectively work with internal and external partners to foster continuum of care. Enhance the quality of services provided by receiving regular training in evidence-based practices such as trauma-informed care and crisis prevention, and utilizing a person-centered, culturally responsive approach. Our core program, we provide housing assistance in facilitating housing, short-term, long-term, and emergency shelter, getting documentation, IDs, birth certificates, medical, financial, and again, getting them as part of the continuum of care. And we'll go into more detail as we go forward. And just to give a definition, as you can see here on the pie chart, 15% of our calls are medical, 9% of them involve getting documents, 5 of them is getting financial, 139 of them, 13% of them is sheltering, and then wellness checkup and rapport building. So the way we took approach to this, as the program started back in December of 2021, is our community health workers, which is comprised of community health workers and EMTs, would go out and walk the streets, mainly in the Chinatown area, an hour walk twice a day, and just engage people. Find the individuals sitting on the street, asking them their name, getting in touch with them, and seeing what kind of services that they would need at that point. And that was part of it here, our wellness. Rebuilding up rapport and getting them to their doctor's appointments, getting them to a clinic or getting them to a place where they could sit down and talk with us and find out what the needs. A lot of the individuals on the street, they don't have an ID. Without an ID, you really have a hard time to get into a certain facility. You don't have your social security card or you don't have a birth certificate. Everything has a chain, right? So if you don't have this, you can't get to there. You try and facilitate them to places that they can get what they need. And a lot of the times there's the extreme. There's the far extreme where people are definitely willing to get help. And then there's the other extreme where people do not want help. And then there's everybody in the middle. So I can say that our approach is not with law enforcement. In the 2 years that we've been doing CORE now, we've had to ask law enforcement to assist us with one person, and that was more so of a bystander. So the approach to the houselessness out there and not having the law enforcement, not having the uniform that myself and Dr. Ireland are wearing today represent more of an emergency. Our CORE staff dresses in a red shirt, they look more welcoming, and that makes a huge difference in the impact that you get with dealing with those on the street. A lot of the financial encounters that we've dealt with, looking for government funding or SNAP or even some type of social security. So we do facilitate that for the staff. Again, documentation, we've had people help with passports, getting their social security card, getting a bus pass, and then getting their ID and certificate, which is over 55% of the cases that we've dealt with. And then shelters. We've successfully placed 44 people into some type of shelter through our core program, and this data is actually only through all of last year of 2022. We'll be able to update it more for this year later. And we've done over 68% referrals, which is getting somebody facilitated into another provider to help facilitate that. Our staffing, so our current staffing today is 3.5 administration, 3 field supervisors, and then 11 community workers that work out in the street. And on the medical side, we have about 14 EMTs, 2 paramedics, 2 nurses, and a physician. Our basics of our staffing is we walk around with the EMTs and the community health workers to engage both to get the facilitation as well as to get the see if they need a medical need. Everybody that we work directly with, we focus primarily on trying to address the medical need. As Dr. Island pointed out, our intention was to decrease overcrowdings in the emergency room, to decrease the 911 calls, which the program has definitely done. It's made a huge impact in the Chinatown and the downtown area, and you can definitely see how they've impacted by preventive of 911 calls and by both interacting with the homeless as well as getting them housed. Most people just, a lot of times they call 911 because they're on the street because they need a social interaction, or a bystander calls because they're soiled. And trying to get the person just from not being soiled is a big challenge, but then also that prevents the 911 calls from coming in the future. Just to kind of give a history real quick, when we first started back in 2021, we only had a total of 9 staff. And we went on maybe like 100 calls. As our staff increased over the time, we were able to do more outreach and more transports with our EMTs. And then as we picked up more staff and we picked up more clients, we were able to, it kind of balanced itself out. So one client we may see 5 times a week for 30 minutes. And one client we may see once a week for 10 minutes. Again, it's depending on the level of the interaction that the client would want and the ability for them to build that rapport. So our core hotline, we always tell everybody 808-768-CORE or 2673. You can call us 24/7 hours a day. If we're not available, you leave a message and we will get back to you within 24 hours. And again, we do remind people that it's not an emergency hotline. It is a resource that we can help to facilitate out there. So the process is...
Go back to the last slide.
Sure.
I think that's just worth noting too. The first 3 core vehicles were city and county EMS ambulances that were ready to go for auction. And we threw some new decals and paint on them and buffed up the engines a little bit. And so those are state licensed BLS ambulances, perfectly good. But we did this really on a shoestring budget to get this launched. And that's one of the vehicles. It actually looks pretty nice.
Elbow grease.
Yes.
So the core hotline rings, a community health worker receives the call, they can gather the information, and together the EMTs and the community health workers go out into the community and they address the person that's sitting at the corner of King and Kalakaua, for example. And they find out what services they need, if they need services, and so forth. We take a very empathetic approach.
One of the other things I just wanted to add here at this slide is we're currently in very active discussion with the governor's office on different technologies, and I know he was just in Japan, on how we can improve our response through apps, maybe direct community to core or community to state notification apps that have, GIS spatial location, so we know exactly where they are, maybe a photo of the incident, because some of these encampments are not in plain view. They're out in the middle of nowhere. And so I think what's happened over the last 6 months is, since we have the new administration in the state level as well as the city, is there's been, I think, a heightened level of collaboration, and I think that will bring some exciting changes in 2024. But right now we have the core hotline.
And through that hotline, as you can see, we've taken over, and this is up until the end of last year, we've taken over 670 calls. And again, they range from everything that we talked about for having somebody be checked on, to somebody that's soiled, to somebody that's lying in front of their shop. If it was somebody to that effect, we do have them. If if you're calling us, we're not able to handle at this point, you can call law enforcement or you can call 911. And then again, our calls broken down here: wellness and wound care, bystanders. The HPD even calls us, or just generalized questions that we got about how they can get some help for the individual sitting on their side of the road. So our data for our community health workers show that 30% of our clients are female, and 63% of our clients are female, 67% of our clients are male. The biggest age is around 60 to 69. We do have clients as old as 80 plus. Throughout the island of Oahu, again, our biggest focus area is within Chinatown, but as you can see, we did go out to every district on the entire island. The 8 different police districts on the entire island we use as a model, and we're actually involved in every one of them. And then
I think what's worth noting here is while we have a regular patrol, quote, patrol area where they do walks through Chinatown, they do walks through Waikiki, sometimes every day, sometimes on certain days, we will do calls to other parts of Oahu, either proactively, like we did a visit to Kailua, we did a visit to the Waianae Coast, we did a visit to, I think, the central Oahu, but we also go in response to calls. So if there were some calls coming in from the Wahiawa area where there was some great concern about some individuals at risk near the transit center there, and we made a special trip out there to identify. So while we do have our routine kind of patrols, we will go anywhere on Oahu.
So we go out on outreach every month. As you can see, we have over 1,000 plus outreaches in that year's time. And what that means is we had roughly about 250 clients on our roster. So some clients, again, would get an outreach every day. Some clients would get an outreach every week. Some would get it every couple weeks. It just mattered on the type of services that they need and they were willing to take at that point in time. And then here's our EMT data. So as Dr. Island mentioned, our EMTs, they are licensed BLS ambulances. They did BLS transport. They were there primarily assisting to provide wound care, as well as to take individuals to doctor's appointments and so forth, as well as also they did play a role in taking some 911 calls that were specifically related to homelessness. A little bit different data, more 37% is female, 64% is male for their clients. Their more peak age is between 50 to 59. And then they took 331% of their calls were specifically related to a call that was self-initiated. 24% of their calls was through the 911 line where somebody called for a homeless individual and the 911 line gave us the call. About 34% of the calls were just pure 911 calls that they took to help support the 911 system, and 10% of the calls were specifically related to mental health. And that's a big challenge. Our core program is able to handle the basic stabilized mental health. Anybody in an acute crisis, they would be transported or they would be responded to by the actual 911 itself. And then to show that the disposition of our clients, a good chunk of our clients was treated and released, meaning we provided wound care and they went back on the street. A lot of the times what it was the individual with the dirty brown bandage that you would see on the side of the road, people would be constantly calling for them. So those individuals, we would try to go out daily and change their bandage, and that way they wouldn't call 911 or a bystander wouldn't call 911. And that's one way of us decreasing the amount of 911 calls, because we commonly got the 911 call, hey, there's this guy sitting at the corner of Smith and Baratania. His bandage is super brown. It looks really bad. Can you guys go and check him out? And what we try to do is prevent that from happening by going out there and changing those things. And then refusals, we did regular refusals. Sometimes people outright refused and just didn't want our services. Short-term shelter type facilities, we work with stabilizations, emergency shelter, transitioning, and we work with the HONU, the city's Department of Community Services project. We also try to get our clients into family residence, groups homes, boarding, the U.S. veteran shelters, or some actually have relocated out of state. So where we placed our 44 clients that we've had in our program, we got them in the boarding home in the U.S. shelters. We got them in-house. Transitional housing, stabilization, we've actually gotten a couple in their own residence. Some have relocated. Some have gone into a group home and then family and then emergency sheltering. The challenge is, a lot of it is the question we always get asked is how much of them are still there, and less than half of them are still there. And the biggest challenge is because of the rules. They have curfews, no drugs, no alcohol, and then just other rules that these individuals sometimes are very challenged at following.
Can we ask some questions here? If you go back
Sure.
to the slide that says shelter types.
Yep.
You know, we have a series of briefings coming up to look at homelessness, and you folks really are teed up as the first one. But taking a look at this, how is it that you connect to the shelter types? It's not something that you contract with. Is it something that you go into the homeless database systems? How does your community health workers, how do your core service workers make that next step to make sure that they get the shelter or get transitioned to shelter?
So, naive me, right? When my background's in EMS, it's in internal medicine, nephrology. If you got high blood pressure, I'm your guy, okay? Homelessness was new for us. I'd taken care of homeless people in the ambulance and the ER when I did ER for 8 years. But the social, mental health dynamics, I knew it superficially. So when course started, I thought, well, we have 2-3 ambulances, each one person a day off the streets. That's a decent target for an 8-hour day. 3 people off the streets a day, do the math, it's $1,000 a year. 3 years we'll be done, right? That's my thinking. Well, 2 problems with that. Number one is we would get the person, and then there wasn't always a place to take them. And I'll let Ian talk a little bit more about that. And that's something we need to fix and can fix and are fixing, but that's a big need. That's one roadblock. Cool. So we have, right now, CORE is the venue to get them off the streets. We have it. So that wasn't there before, we have it now. Part 2, the second thing, the person who tells you very colorfully where to go. They don't want our help. And a lot of times that's because they're very, very mentally ill or very, very profoundly affected by substance abuse. And they're so unwell that we probably have the legal means to involuntarily remove them from the streets. But again, like an airplane coming to the airport, you need a place to land. So I think we now have the venue to get people off the streets. Housing or permanent supportive housing with nonprofits giving supportive care when need be is the end goal. But there's this in between that I think would be a good goal to work on for next year, and we are working on it. But I think it's all hands on deck for that part.
What is that in between? So it's not permanent supportive housing, but
it's more shelter space, it's medical respite, and it's mental health space where people can be placed where they're not in danger to themselves or others. And I think just recently, what we saw at the state hospital, we know, and we've known this, that people who have decompensated mental health issues can be dangerous. And so it has to be a safe space for them and whoever's taking care of them. But with that, I'll let Ian talk about how and where we take people.
No problem. So part of it, again, yes, Chair, we work with the HMIS system, Homeless Management Information System, and we work with the Centralized Entry Services, so CES and HMIS. We work facilitating through that for the individuals that are able to do it that way. So again, if there's individuals that we found, I'll give you an example of a client. We found a client that had $30,000 in the bank account. But the client knew he had money but never had an ID, didn't have birth certificate, didn't have anything. So we facilitated, as that client was on the street, we facilitated that client didn't want to go into emergency sheltering, didn't want to do anything, just stayed on the street. But one day after months of working with that client, we were able to get all the documents, got the documents, found the client a boarding home. God was able to get the client to pay the monthly for that boarding home, and that client was facilitated that way. So it matters on the resources and the ability of the client that wants the services and how they're able to get it. Otherwise, we do work through the system, and we also work through the ability of whatever the individual has available to them at that point in time.
So when you say the system, you work through the system, I mean, you don't have to speak to all of it, but the partners you're working with.
Well,
It's-
we work with partners in care. I mean, you facilitate with PIC, and then they have everybody as the big care continuum with IHS and so forth, right? But working with them, Catholic Charities, working with the different facilities on the west side of the island and so forth. And the state's homeless website, they have all the different names of all the houseless facilities that somebody could get an emergency shelter at, and the availability, as Dr. Island pointed out. But everybody still has some minimal rules that you have to follow to get in there. And I think that's the biggest challenge for taking an individual that is houseless and placing them into a place, is explaining to them, these are the rules that you're gonna have to follow, and majority of them don't wanna, I still wanna be able to drink alcohol and do this, or I still wanna be able to find my drugs. It's very difficult to take somebody from the urban core area and secure them housing on the west side of the island, which we've had. By the next day, they caught the bus back. So having the facilities available in the key parts of the island where the individuals don't have to travel too far and they don't lose out their connection is important. And we've realized that early on, that I got you a house and we take in the client all the way to the west side, and within the day they were catching a bus back. We brought them back, they caught the bus back the next day. So that wasn't working.
And then there's barriers as well that we're learning as we go. So for instance, someone won't go without their dog. Okay, there's a barrier. When COVID vaccine was a requirement, that potentially was a barrier. Although if they were willing to take the vaccine, the core staff would give them the vaccine. Prior disruptive behavior when they've been banned from a facility. Sometimes people have convictions, especially if they're a sex offender, which is a barrier. And then like Ian said, their continued desire to do illegal activity, smoke meth, drink, and do these things in the shelter environment and be disruptive, that's not conducive. But I think looking forward, at least on the island of Oahu, having a node or a place where everybody could go that's homeless and then get distributed out for their best fit might be something that would be helpful. Now, and then the other thing is placement of that facility is key too, because many communities are sensitive to having homeless from outside the area coming into their area, even if it's a node, to disperse people out to other shelters or housing. So we understand that as well. The other thing we've learned is, for instance, my visits to the homeless encampments on West Oahu, a lot of the folks in those areas are born and raised in West Oahu. They have no interest in coming to anything on other parts of the island, especially downtown or Chinatown or Iwalei. They want to stay in their community. So in some ways, those solutions have to be for that community. I would say in the Waikiki, Moiliili, and downtown Chinatown areas, that's a higher proportion of people who aren't even from Hawaii. Maybe they're new here, they got a plane ticket, and that's an issue as well too. People getting one-way tickets and they've been here a week and they have substance issues or mental health issues, and how do we best support them? And people with mental health issues are best supported by people that are their loved ones or care about them, which may be back in another state or somewhere else, to get them back to their loved ones. And of course facilitated that somewhat in getting people back to, that aren't from Hawaii, back to where they have more support.
So our housed individuals, 36% again are female, 63% were male. And here on the next slide, it actually shows you some of our successes. So in the top left-hand corner, we talk about a 33-year-old male that was unsheltered for 5 years, and we were able to place him in a day. And that's simple as getting them into an emergency shelter that was available. But if you go all the way to the bottom, right at the bottom, we had a 67-year-old male that's been on the street for 10 years. It took CORE 82 days of interaction with the individual, building the rapport, getting them to trust us, getting us to work with the system and go forth. And then everybody in between. Some people, 72-year male, 14 years unsheltered, but CORE got him placed in 44 days. The approach that our staff took and the approach that we took for the program is, one person at a time. And we're gonna work with that person and spend as much time with them. And it's difficult. There's a lot of homeless out there that you have to build that rapport with. You can see the person on the street, but if you're not building that rapport with them and the hundreds and thousands of hours that people are spending directly with them to get them the counseling, to get them the services, to get them the resources that they need is vital for this success for that. The ones that are done in 1 day, 3 days, 5 days is mainly because they just couldn't find a place. They had all the documents and they needed some place to stay. And again, we start at the lowest level, which is emergency sheltering, just getting them off the street and getting them to that place. But as Dr. Island pointed out, again, at every level, we do have limited resources in the ability to do those things. The next slide is our top frequent clients. So these guys are not even sheltered. 53-year-old male, unsheltered 8 years. Our main interaction with them is providing 90% of the time wound care and transportation to the clinic. He has a substance use disorder, SUD. So working with that person and then trying to limit the amount of times they call 911. Yeah. 52-year female, mainly wellness check, interaction, getting documentation, but has severe schizophrenia. Those are just examples of the clients that we deal out there with that make it very challenging for the community and our staff because, again, you know that they need the help, they want the help, but they're not quite clear of following through. The 51-year-old female, I interacted with this individual. I was there, they worked with her, they got her on a plane to go to back to American Samoa, and within a week she came back. Because again, some of these individuals, their lifestyle that they've accustomed to already, they're used to it being the way they are. And it makes it very challenging. But those are the ones that are chronic that you deal with on the streets all the time. So this just gives a recap of the earlier part of this year of the outreaches that we've done and the resources that we provided and how many more additional consumers we placed this calendar year. In the first part of the year, January through May, we placed an additional 10 consumers into some type of housing and added additional 55 consumers onto our resources. As Dr. Ireland pointed out, that one of the biggest challenges that he realized in the beginning is finding the resources. So the city took on a new venture back in June of this year, where we created our own medical respite. There's been successes, and there's been a lot of lessons learned that we've had from that. We opened our medical respite, which is at the Evole Resource Center.
And I'll just stop you really quick right there to say why we did this. If you have a medical issue, you can't go to HONU, which is the city's pop-up shelter. IHS may or may not take you. Some of the others won't take you, like an amputation, a fresh surgical wound. And so this need for medical respite for homeless came up. There are 3 other medical respites right now open, besides this one Ian's going to talk about, but they all have capacity of around 5 to 10 people each, roughly.
So, and we talk about medical respite. If you are unable to perform your activities of daily living, where you can't give yourself a bath, where you can't take care of yourself and feed yourself, we're not the place for you. They would need to be in some type of skilled nursing facility or nursing home. Our place is where you think about it. If you could go to a shelter, you're fine. Or if you could go home, you're fine. If you had a house. The medical care that we provide are for individuals. We're like the person's home. If the doctor was to discharge you home, you would be able to take care of yourself at home. We help facilitate that, but we don't go above and beyond that. We don't have the skilled nursing facilities capable or the setup for that type of thing. So ours is it's a shelter, but a step above the shelter. So if you have untreated mental health, your behavioral is violent, you just wanted a place to sleep, we weren't providing you the services there. So again, this is just a picture of our resource center, a building at the corner of Evole and Sumner. This is what it looked like, an empty dining hall area. Pretty empty dining hall. We brought in some hospital beds. This is our progress of us getting the place ready. And we staffed it out to full of 19 actual hospital beds inside there. The facility is air conditioned, HEPA filters, had a full kitchen and multiple rooms. This is different rooms that we set up for the staff for supply, for storage, for getting everything ready for our staff. And then we had access to the full commercial kitchen, which we do have a food permit license for. So we do cook and provide the food for the homeless there directly. And then this is our staff getting ready for our staff meeting before we open. We opened back in June, middle and late part of June. We had our first 3 clients come in that day. This is an example of our staff providing some wound care to one of our clients. So we've actually had 19 clients that we've actually approved for some type of admission. Today, physically, we have 4. And people have stayed at various lengths. We have 1 client that's been there from the first day and hasn't left us yet. The goal is, again, taking somebody with a medical condition, facilitating them, getting them well enough that they are able to go and find independent housing or some type of shelter outside of this place. Once we got them to that level, we have not, we facilitated them out. To this day, we have majority of our clients that have left because one person wanted to go out and get to drink. The other person just didn't like it there anymore. A lot of them had to go back and find their vices that they had in life that we were not providing. Our rule is that you come in, we get you better, we facilitate your housing. We are not an in and out facility. Because again, we would not want to risk the chance of them bringing in drugs or other types of things into the facility that could hurt other people. So our facility is a safe facility where you could guarantee that they would not have access to anything that could hurt somebody. So since we started, and this is as of last month, we've had 92 referrals. We've only approved 19 people. And that the 73 of them were denied because they needed some type of excessive health care, either a skilled nursing facility would provide or a substance abuse or mental health. And 80% of them are males, 20% is females. And again, this is as of last week. So right now, again, one person actually did get housing. We got a person into a veteran housing out in Barbers Point. So that individual was a part of the rapid rehousing program and a work program. So they actually got a job as a security guard. We got that person facilitated to take the security guard exam. They got the job, and then they got the housing for it. And we're working with that client. So even though the client left us, we're still checking up on the client and working with the other providers to ensure that that person stays in the housing. And we have a couple other 2 pending right now. Again, it's finding the right place for the individuals and making sure that they're able to get there. And the last 2 clients, they kind of need some foster care. There's no way that they would be able, they're not, how do I put it? They don't need skilled nursing, but they do need supervision.
So just a couple comments on that slide. One is what this told us, this experience over the last few months, is that we do need to have a higher level of care so we can take more people in. We can manage these referrals. The other thing is we're in kind of a group setting. Everybody's bed is in one big room. We needed a little more individualized. And so we're in the process of moving this facility to Leahi Hospital. And there's space there that is unused that we'll be able to use. Again, we're going to maintain the no in or out privileges. We're not going to have people coming in and out. They're going to be in the unit until they're ready for discharge. We're also looking at bringing in some outside expertise for mental health services in particular to enhance the level of care we can provide so we can take a larger percentage of the referrals. So that's in the works. Probably going to be next month when we move. So that's some of the other reasons why the numbers are artificially low, because we've tried to downsize prior to the move so we don't have to move as many people. But I think this experience has taught us kind of how to fine tune this to actually make it more efficient for what we need to do to get people off the streets.
In addition to that, this experience has shown us that we went from an outreach program to a respite program, we're going to go back to outreach. We were providing the outreach for the last 2 years, and to staff and run this respite, we actually stopped outreaches, which has put a little challenge on the services that we've been providing. Spread it out, our outreaches. So the amount of staff that we required for the outreach, all that staff, the services was rededicated to run this respite 24 hours a day, 7 days a week. And we're going to go back out to outreach services. Funding for this, the question we get asked, the funding for this is currently, we do have some general fund money from the city, but a lot of it does come from the FRF money that the city has received, the federal relief money, the COVID money, SLFRF. So we are benefiting from that which expires at the end of next year. So we do need to find other resources for the city to continue our services for this program. We do have something worked out with the Department of Human Services now for some services, and also with Department of Health for some post-COVID money to address some COVID-specific related to the houselessness.
So I think this respite program at Leahi until June
Yes.
is funded through funding we received just last week from DHS, which we appreciate.
Time for questions?
Yep, no, and that is the end of our presentation, Chair. So if there's any other questions, we are open for the questions.
Members? Yes, Vice Chair.
With the move to Leahi, how many beds do you guys currently have at Evile, and then how many is that going to expand to?
We're
at
going to
Leahi?
try and, we have currently 19 beds, and we're going to try and still maximize it at 19. If there's an opportunity to provide more, depending on, again, on the safety and the types of clients, we would try to go more, but it probably won't go more than the mid-20s. But it's more about the facility size and the safety part.
Physical space, we could probably fit 26 would probably be the max. And that would be a few, using some double rooms. Two patients to one room.
Oh, okay.
We
and
could go up to
26
26.
is the total in that space.
Probably the max, yeah. But I think probably closer to around 20 would be comfortable.
And
Represent-
when's that move happening? Is it?
We don't have a definite date. There's
Okay.
still some processes that are in progress that need to be finalized. But we'll keep you apprised of
Best
progress.
guess in December, which is next month.
Representative, any questions? Okay, Director, I think you said something curious, and I appreciate that what we're doing is learning through this experience, because I think, I don't know if you ever received Ohana Zone monies, but when we did pass the law to create Ohana Zones, we had actually did an appropriation also for medical respite. I don't know that those funds were ever used, but the whole concept at that time was that we have to be more nimble about the solutions to address homelessness. And I think we've learned a lot over time about where our gaps are. So you've talked a little about that, and you said at one point that we need to have higher levels of care. I've seen references to things like needing more mental health treatment, mental health capacity, and then also the persistence of substance abuse with this one subpopulation. And we have to recognize it's only one subpopulation of the homeless community, but it is actually probably the one that our constituents sometimes see most visibly. So I guess, can you comment? I think what I heard is that one of the things you learned is that you folks are good at outreach. The respite part of it, which really requires more higher level of care and services and skills, that would be resourced out in contracts with providers who can deal with that. Is that a correct, accurate?
Absolutely.
Okay.
And so for our Leahi Medical Respite, we are in the process of procuring a nonprofit with expertise in this area to manage and run that program, possibly with some shared staffing with one of our local health systems to provide psychiatric support and possibly some nursing support. So they can take, because where these folks stay is the hospitals. And if you're in a hospital for 100 days because there's no place for you to go, that then holds up that bed in the hospital that's needed for a trauma patient or somebody who's been in a heart attack or what have you. And so it will help get people off the streets, but it will also help alleviate our hospital congestion as well.
And I guess one of the things that I'm hearing is that as you build up more partnerships with these other hospitals, service providers, you guys will then be able to focus on the outreach, which you're good at, and you can bill for at some point in the future, we hope. But that the rest of the system has to come up with the resources and kind of the assistance and the support for that respite, that medical care, the housing support system, and that's not in your Kuleana.
Well, at the city, we do have an Office of Housing. We have a community services department that handles things like Section 8 vouchers and delivery of HUD money and a lot of other programs. CORE is one piece of the city's response, but I talked about this kind of node where we put everybody in. So unfortunately right now, as you drive down King Street, 12th Avenue, Mauna Kea Street, we see the evidence of homelessness, and all over the island, really, if you look. We talk about numbers, and we're proud of our numbers and what we've gotten done, but really it's almost this visual test that goes beyond the numbers, because you can just see. Let's go across the street on this campus. You can see it, and so we need, I think, this clearinghouse or place where people can come safely, get their medical care, their psychiatric care, and then that decides then where they go out. CORE can be the street liaison for that. Mm-hmm. CORE can help be the kind of the glue or organizer that connects these places together. But we have a lot of moving parts in the city and state and nonprofit world taking care of this. And I think we have an opportunity in 2024 to get those gears better aligned. Everybody's working very hard, but I think there could be some synergy if we worked all together a little better. And in fairness, the last 3.5 years, people have been distracted. They've been trying to survive COVID, medically, economically. But now that COVID's largely behind us, we have to look back at some of the issues that have been affecting us for a long time. And what I tell everybody on our team is this: if homelessness was easy, it would have been fixed already. And all across the country, we're not unique. And we're better in many places we're better. And in some places, are better than us. And so we're trying to learn from what works and has worked on the mainland to bring it here. But again, not make the mistakes other places in the mainland have made. And we have a unique system here too, because we're so isolated. But I think the opportunity in 2024 with this synergy between the city and the state and the interest now in this area, because too, people who live and visit here have a right to feel safe in their neighborhoods and on their in their beaches and at their parks, and so that's an issue as well. And at the end of the day, these are all humans that are homeless. They're all people that are related to somebody, brothers and sisters and parents and children, and we want to help them. But at some point, if they are resistant to that, we have to use the tools, whether it's involuntary holds. And there's lawlessness amongst the homeless. Homelessness is not a crime, but there are criminals hiding in these encampments and amongst the homeless. And I think once we kind of peel that back and help the people that we can help, we leave the criminal element there naked, still doing the crimes and victimizing people, and then we leave that to law enforcement and let them focus on those folks.
I really appreciate what you just kind of summarized, because it is in fact teeing us up for the conversations we have, and that I think the approach this committee is taking is to look at it as a system, as an ecosystem, and that there are all of these different parts in community that take responsibility for it. So we do have your counterpart. We hope that Mr. Crucky will be joining us in a future informational briefing. And I think one last question I would have, or two last questions. So that thing that you're talking about, that hub, is that like a stabilization center that we've had conversations about here at the state level? Because for us, I think one of the things that we had identified last session was the need for a stabilization center, maybe not, maybe for a few days, 24 hours, but to give that opportunity to assess and then determine. Is that somewhat along the lines of what you're talking about as that hub? Yeah,
that's one word for it, sure.
Okay.
Because what I, as a provider, as kind of with the core team, and I go out with them, and when we get somebody off the streets, I don't want to hear, you can't come here because, and fill in the blank. whatever shelter, whatever system. The ERs always take people because they have to. But that's not appropriate for the ERs a lot of times. And then what do? Well, then you see folks a block from the ER that don't need to be in the hospital. And that's really unfair to the hospitals because folks are going there that don't need to be there. So I don't want to hear they can't come because, or we've actually taken people in core to fill in the blank, one of the places that we normally go, and they've said, no, you can't come here, we're full. Or you can't come here because. Well, then what am I supposed to do? Go drop them off back on the sidewalk? And one of the things with core is I've really tried to impress on them, I don't want you discharging people to the streets. You know, I don't want you, they have to go somewhere that's acceptable, and that's a real challenge. So I want a place where people can go, where core can take them, people can walk off the streets, and from that place, we figure out where is the best place for them to go. It's very similar to like, you know, I really think that, and you know, Anton Krucki invented core. You know, Ian poured the gasoline on it and got it going, but Ian, it was Anton's vision that got us here. And it's really very similar to EMS and the whole 911 system for us. And that's, I think, how it came in our department, because when you call 911, you need help. The ambulance comes, they know what to do. Dispatch coordinates where all the ambulances are going. They go to the hospital you're supposed to go to. You know, if you're pregnant and you go to Queens West where they don't have delivery services, then Queens West figures out which hospital you're going to go to deliver your baby. So we are kind of looking at this the same way. Core gets dispatched through the core hotline or an app or something to this homeless encampment. We get people, we get them out of there if they're willing. If they're not, we look at a hold situation if that's appropriate, involuntary hold, and we take them somewhere that we know we can take them that's not going to tell us no. From that place, that's like, let's say the ER, then do they go to the ICU? Do they go to the medical, do they go to the operating room? Do they go to the medical floor? You know, and that may not be physically in the same space, but maybe people do need to go to the state hospital from this hub, or maybe they do need to go to just the regular shelter. Maybe they need to go to medical respite. But then you have that opportunity, number one, to just have someplace to go, and then go to the secondary move. And again, housing's the goal. But what I found in, like, when our own clients have needed Section 8, that's not instantaneous. As a matter of fact, it's often weeks. And so where does someone stay while you're waiting for that housing voucher, or while you're waiting to be placed somewhere? And I do think there's a role for small house villages. I do think there's a role for vertical housing, buildings. But at the same time, we know there are some segments of our population that will never be able to live by themselves. And that's why if you have someone with severe mental illness or drug abuse, and you put them in the nicest home in the nicest neighborhood in this island, that house will be destroyed in a matter of a few weeks, because they need someone to make sure they take their medications. They need someone to help direct them if they're feeling a little off the path. And that's why some of these, like maybe group homes, or where you have a resident manager who can really help with those who are stable enough to be out of, for instance, the state hospital or another facility, but not maybe ever well enough to be living independently.
So actually, that's the perfect place I want to sort of end on, because in your slides, one of the things that you discussed and was a persistent challenge is the substance abuse. It's the alcohol abuse. And if we look at it from a medical perspective, that's addiction that needs to be treated. So I know you don't have the answers, but you started to say it, I think, which is that we need more group homes that are trained and able to take care of those folks who have those kinds of disorders. Again, that's not in your realm of expertise, but it would be in service providers.
Correct.
Okay. And then we build up that capacity how? Now I'm going to put you on the spot. How do we do that?
So there are some facilities now that do this type of work, and I don't know them all, but what comes to mind is like Hinamauka, Sand Island Treatment Center, and others. But I think looking again at models within our community that have worked, and maybe outside of our community, and either making the capacity of those facilities larger or duplicating them in other parts of the island or the state. Because, you know, there's things that work and don't work, and obviously we want to recreate the stuff that works. But what we need is actually choice E, all of the above. But it's more of, like you alluded to, the psychiatric facilities and the mental health, and as well as the substance abuse, where really that's not a puka, but an area that we definitely need to probably most improve on.
Okay. Representative.
Just a comment. I mean, part of the answer might be this. I mean, I think it's a shame to have a facility like this, city-owned, full kitchen, you said AC, just
Yeah.
sitting there. I mean, somehow, I think there might be a use for this.
And I think that is for a future informational briefing.
It is.
Wow.
We have big
For the
plans.
city.
It could be for us as well. We have a responsibility in this as well.
Yeah, we have some discussions ongoing with the state, and I'd let the state comment on what their plans are, but we have big plans for that facility. So the state is going to help us in a city facility, and the city is going to use a state facility, but I think that's the kind of collaboration we're looking at as best fit.
Thank you.
Any further questions? I will leave this for you, closing comments.
For once, I don't have much to say, but we appreciate
we
the
have this on
time.
record, Dr. Ireland. I really appreciate you folks taking the time to explain this to us. I know you're getting various phone calls from my colleagues on Oahu Island. I know that folks around the island, around the state, are looking at what you folks are doing and hoping for the very best, because I think this is part of the ecosystem. This is part of the many solutions we need to work on to address homelessness. So thank you for the work that you do. Thank you for all the work that was done during COVID. I do think that we have this opportunity in 2024 to do some amazing things, and I'm looking forward to working with the City and County of Honolulu.
Thank you.
Members, with that, we are adjourned.
Thank you.